Because
no, carry on. Yes.
Brilliant. Sorry, I completely forgot. So yeah, I mean, basically working with diastasis makes a pathway for umbilical hernias. So that's why I've kind of worked out my knowledge with this topic. Now, Sarah, I can see you nodding. Give me a little bit of background about you. How come you're interested in hernias?
I'm a ginger. I've done the ACMT and the fascial course and a few other bits. I have always worked with a lot of older people, and so I think because of the way things are, I've had a number of clients who've had mainly inguinal hernias, and I didn't know what to do, and I mean, that wasn't what they came for, you know, they just had them alongside other things. And I currently have a couple of clients who have them. And I just kind of managed my way around it, but very unconfidently. And yeah, just thought, I wish I knew a lot more about this. And then a new client who is actually a neighbour, and I need to talk really quietly because you could probably hear me otherwise, came with a bad back, but mentioned at the very last second, that actually got a hernia as well. And it's kind of doubly embarrassing because he's a neighbour as well. So he really doesn't kind of... So we're really edging our way around it. So I really want to fill in lots of gaps and learn from your considerable experience.
Well, I hope that I can advise and help and give you information. Now, is there anybody here who has not done the ACMT? That's fine. It's not a problem. It's just so I know, because I've created a presentation, so I'm going to cover quite a lot of stuff. If there's stuff or anatomy that you don't understand, please feel free to ask questions afterwards, okay? I'll show you I'm just going to see, we've got 1, 2, 3. Actually, this is being recorded, so somebody else, they can watch the recording, because we did say 4:15. So I'm going to share my screen, if that's okay. And hopefully this is going to work. Okay, so this is it. I'm quite excited. I've never done one of these before. So please bear with me if I stumble in my words or whatever, you know, sort of be kind. Let me just see. When you're looking at the screen, can you see yourselves as in the little row? Because I've got a row.
And you.
Okay. But you can see the whole screen of the presentation.
Yeah. Yes.
Okay, so anatomy, hernias, and myofascial release. So here we go. With hernias, as you can see from this image, there are many different types of hernias. The ones that I predominantly work with are umbilical hernias, incisional hernias, inguinal hernias. I've seen a femoral hernia, but it's not very common in my clinic. I haven't really dealt with it. And the epigastric hernia, solely the umbilical and the epigastric is because of the diastasis that I work with. The symptoms of hernia, usually you don't have any pain. Okay, you might have a bulge, but you will not have any pain. And if you'll have the bulge, it will be different sizes, different shapes. Okay, let me start again. You'll have increased pain at the site at times, not always, because they're asymptomatic most of the time. If there is pain, you need to keep an eye on them, or the client needs to keep an eye on it. They might have pain, or it might kind of grip when they're lifting something heavy, and it may increase over time. It might be kind of a humming, dull ache in the background, or a sense of fullness or a bowel obstruction. Now, I'm going to explain the bowel obstruction in a minute. Basically, this is what a bowel obstruction could be or could cause. So if a hernia, if you have somebody that turns up into your clinic and they have a very bright red bulge, or they have a lot of pain, or they're obviously vomiting or have fever, please, please, please send them straight to A&E. Because basically what's happened is that their hernia has been strangulated. And what that means is that their bowel has protruded out and the tissue is starting to die. So therefore they would have to have an operation to cut the intestine at some point, depending where it is, and sew it back up. And that can be very dangerous. That can at times be life-threatening. But it's rare, okay? It doesn't happen all the time. The reasons for hernias, there are many different types of reasons. Chronic coughing can be one, chronic constipation. Being overweight and obese is a big one, because that's basically putting a massive amount of strain onto the stomach muscles. Lifting heavy weights and lifting them incorrectly. So for example, I had a client who is a bodybuilder, and he had massive muscles in his shoulders, massive muscles in his back, but he had no connection whatsoever when it came to his abdominals and his core stability. So he was doing it all from his shoulders without engaging his core, which meant that basically he ended up with a massive hernia in his umbilicus, as well as actually developing diastasis. Yoga, I know that's quite surprising. Yoga can cause hernias because of the overstretching that is caused. And if you have very dry connective tissue, fascial tissue, so maybe the collagen's being impacted, or you're not actually, again, engaging your core in the right way, so you're just stretching it without actually connecting with it, you can cause predominantly inguinal hernias with that one. Pregnancy can put massive amounts of pressure on the abdominals. This lovely lady, you can see that she's lost loads of weight, she's super fit, she's a runner, but you can see that she's had diastasis, because this is one of the side effects of diastasis. And if you look at her umbilicus, it's kind of changed shape completely. So you can see that she's had a hernia. Now, this chap here, you can see that he's had quite a significant hernia there. With hernias, if you think of the different layers of the abdominal wall, it has to go through various layers. So it depends on how severe the hernia is. Now, inguinal hernias are the most common hernia. 80% of all hernia cases are inguinal hernias. Now, there are many different types of hernias. We're going to cover all of those today, or most of those today. You have inguinal hernias, umbilical hernias, hiatal hernias, or hiatal hernias. That's an internal hernia, that's inside of you. Then you have femoral, which are kind of on, sort of following it's on the other side of the leg. So the inguinal follows the inguinal canal here, and the femoral is underneath. And then you have incision hernias, which basically means that they come out after an operation, but I'll cover that in a second. Inguinal hernias also are male orientated. The majority of people that get it are men. I don't know why. I have a vague idea. If you think of what they do to relieve themselves, potentially the banging could cause an issue on the connective tissue of that area. There is the connective tissue in the area of the inguinal canal and basically the hip flexors is very, very thin in comparison to all the others. So that's why it's a very common hernia. And to repair that particular hernia, usually because it's such thin connective tissue, they use a mesh. And I will go through that in a second. So umbilical hernias. Umbilical hernias, on the other hand, they're more common with women, and they're very common after pregnancy. They are very common in obese people, and they're also common in children. So newborns and babies can have umbilical hernias. When it comes to babies, my theory is that potentially it could be, when they're kind of cutting the umbilical cord, it could be that they damage the connective tissue of that area in the child. And when it comes to men and women, it's because basically the abdominal wall has expanded out. So these ladies have all got diastasis, different forms of diastasis. And you can see this one has a hernia. This one you can see because it kind of pops out. This one has a hernia. You can see how there's a little overflap that is hanging over the actual umbilicals. This one doesn't. She seems to only have diastasis. This one only has diastasis because it's quite contained in the belly button. And this one has severe diastasis and an umbilical hernia. So, incisional hernias. I know that image for me was quite shocking when I was looking for images. You can see that the poor chap is quite obese. Now, this can happen, let's say, if he's had an operation to fix a hernia, and then the operation, the connective tissue didn't heal properly, another hernia may come out of that one. It also depends on how they did the operation originally. If it's a hernia operation, if they used a mesh, it's quite unlikely that they would be receiving another incisional hernia. But it really varies. We'll discuss in a second how they repair it. Now, what's very interesting with incisional hernias is that it's very common with hernias that deal with gallbladder, appendix, and basically re-damaging your hernia. And that's because people are not following the correct recovery program per se. They ignore the advice from the doctors, they start lifting heavy weights, or they put pressure on the abdominals, or for example, they're constipated, which tends to happen post-operative, and they put a lot of pressure in the abdominal cavity, which could potentially just pop that hernia or pop that connective tissue again. Now, I'm not going to go in massive detail with hiatal hernias, but because we were talking about hernias, I thought it's important for you to understand what a hiatal hernia is, especially if a client comes in and explains that they have one. That basically means that the diaphragm has either a hole in it, but usually is because the esophagus, which is one of the things, you have two items, but predominantly the esophagus is the one that goes all the way through the diaphragm. And basically the hole that usually allows the esophagus to go through gets too big. And if it gets too big, then you have the stomach that can protrude into the upper cavity, so the thoracic area. And that can cause acid reflux. So if you have somebody that has a lot of acid reflux, ask them whether they have been checked out for a hiatal hernia, which could be the reason why they've got it. And the reason why they have the acid reflux is because the stomach is above, the acidity juices that happen when you eat go up into the esophagus, whereas usually if it sits where the diaphragm is, it kind of stops it from going up. What else? There are various degrees of protrusion. So for example, this one is the standard, the normal, but sometimes when it's really bad, you can have literally the whole stomach above the diaphragm. And those are quite dangerous ones. Usually they are dealt with just medication, but it depends on the degree of the extent of the hernia that they might have to operate, because again, you might have strangulation of the organ and then the organ can die, which is basically not good news. Right, So this is where it gets interesting. Hernias occur when there's a weakness or a hole in the peritoneum and the aponeurosis of the abdominal wall. Now, for the ones that don't have massive amounts of knowledge when it comes to anatomy, first I recommend that you really learn your anatomy. But in the meantime, the peritoneal cavity is this yellow area. So this is a cross-section of the human body. And the yellow section is the peritoneal cavity. So it's kind of like a sac where all your organs sit. And then you have the peritoneal sheet or sac, which holds all of the organs inside. Okay, so all this red line here is the peritoneal. And then above that, you have, would be your tummy, you would have the aponeurosis. And I'll explain to you in a minute graphically what the aponeurosis is, but it's basically the rectus sheath. It's basically where all the connective tissue sits above, underneath the rectus abdominis. Now, when you have damage or hole or weakness in this area, you will have a hernia. Right, here we go. So aponeurosis is this pearly white fibrous tissue. Okay, this is basically, if you look at the shadow that you have here, this is where your rectus abdominis would be. And it goes all the way down. And then if you removed the rectus abdominis completely, this is what would be underneath, okay? The line in the middle is called the linea alba, which is the line that actually gets damaged when you have diastasis. And basically all the muscles connect here. So you can see the cut section here of the external obliques. The internal obliques are underneath that. And underneath that, you have the transverses. Okay, so here you can see it better. Now, I chose this image rather than any other because this image has the pyramidialis. Not everybody has this little muscle here. It's tiny, you can see it here. It's like a little triangle. Obviously it's on both sides, yeah? Not everybody has it. Why that's the case, I have no idea. But you can see that here you have the rectus abdominis sitting above. This is the rectus abdominis sheath or the aponeurosis. Then you have underneath that the internal obliques, external obliques, transverses. Now, when you have an inguinal hernia, you can see here the color of the rectus sheath or the aponeurosis. You can see how much there is. There's no muscle there at all on both sides. So that's why it's very, very thin. It's very flexible. Oh, yep. And that is why you can get a hernia there. Now you can see all the way around. It's called the six-pack. People call it the six-pack. Everyone has a six-pack. No matter how big or small you are, everybody has a six-pack because it's basically the connective tissue. Now, some people have it more defined because they have less adipose tissue, which is basically less fat. But everybody has these lines, okay? And within these lines is where you can potentially get hernias because there's a lot more movement and it's basically, the way that I say it to clients is imagine a plastic bag that you're stretching out. Now, this is a quick anatomy lesson when it comes to the rectus abdominis. I found this really fascinating when I was studying anatomy. This is a cross-section of the rectus abdominis, and zoomed in version. This is above and this is below the rectus abdominis. So above and then below. Okay. And if you look closely above, you have the transverses go all the way. They join underneath the rectus abdominis, as well as you have the internal obliques that get divided into two and go above and below. And then you have the external that goes above, that goes above completely. Now, what's very interesting is that the section below doesn't have it. Okay, they all merge together to join at the top. Now, this is the linea alba, this is the center of the body. And then you can see, obviously, with hernias, this section here has less, to an extent, protection in the lower section. Okay, you're gonna wonder why I put hot cross buns and plastic bags. But this is how I explain it to my clients that have diastasis, okay? Diastasis predominantly looks at the center line. You can get it in bodybuilders, hence I chose this muscular image, and you can get it in pregnancy. And what it looks like, or what I try and use the analogy is, imagine a hot cross bun. What happens when you have a hot cross bun? It expands everything out, and then it stretches the lines, hence why your little cross in your hot cross bun becomes bigger. Now, the plastic bag analogy is, I don't know if you've ever grabbed a plastic bag and stretched it just a little bit. And if you stretch it too much, it breaks. But if you stretch it just enough, you can still use it, even though it's lost its ability to function properly. Now, that is basically what happens to the linea alba when you're pregnant or when you're obese. If you stretch your plastic bag just a tad too much, what happens is that it breaks. And that's when you get an umbilical hernia, or the hernia above, just here, the epigastric hernia. Now, this is just, I've just thought a further anatomy image. You can see how the aponeurosis goes from the top of your sternum all the way down to the pubic bone and the hip bone. Now, remember that we're 3D, and remember that all of this is muscular. So all of it is fascia and muscle. But you can see that the cavity in here, where the inguinal hernia would appear. Okay, so how the different types of repairs. You have open surgery, which is basically when they completely open you up and then sew you back up. That's more of a reconstructive, sort of, that's when it's quite severe, and that you might have maybe more than one hernia, so they will open you up and do it all in one go. Laparoscopy is usually the way that they prefer to do a hernia, unless it's a massive hernia. And that's basically when they do keyhole surgery. Now, I wanted to show this image because I found it fascinating that these three women have diastasis. Sorry, this man, he's a man. So this man and these two women have diastasis and hernias. You can see the little dots. Now, what I find fascinating with this, and I couldn't find a good enough image to show you, but what they do is they blow you up with air so that they can really get the tools in. And they turn a light on to work out exactly where the light is in. It's one of these tools. They turn a light on to work out exactly where the connective tissue is and how it looks. And then they're able to operate through keyhole. But sometimes they might say that you're going to have keyhole, and then they take you into hospital, they start surgery, and then they realize that actually the connective tissue, the collagen and everything is not as best as it could be for for keyholes, so they have to do an open surgery. And this is why myofascial release is so important pre-surgery, because you're basically allowing all of this connective tissue to be in the right place with no adhesions and be happy, so that they can actually do a better job and potentially not do open surgery. How they fix it, and I forgot to put one extra point here, which is they can either sew you up, so, you know, as a normal suture, or you have 3 different types of mesh. You can see the top left-hand corner, all the different types of mesh. I think there's even more than this. This is a plug, and this is the one that they tend to use more when it comes to inguinal hernias, as well as femoral hernias. Now, the mesh is a tricky one, because obviously if you have a massive hernia and it needs to be plugged up, that's all you've got. But what's interesting is what they choose or what they have to hand. If I were to have a mesh, I would probably go for biological material, because it's animal tissue. So it will be absorbed by the body. It won't necessarily be an issue, a permanent issue, and it won't migrate. One of the problems with meshes is that they can migrate. They can move from the position that you have them in. The polyester mesh is very good, but it has a shrinkage, which is not great. So if you are if you're an individual that suffers from obesity, so therefore you go up and down with your weight, you wouldn't necessarily want something that's going to shrink. And with the synthetic mesh, obviously it's not real. It's monofilament fibers. One of the side effects with these 2 meshes is that they not only can they migrate, but some people feel them. They can have infection. Basically, your body will react because it's a foreign entity. But as I say, please, you know, sort of, I wouldn't explain this to clients. I'm just explaining it to you. It's important that the client needs to follow the medical advice. So for A or B reason, they will choose the type of mesh that is suitable for them. And, you know, we hope that they'll do the correct job. Now, how to prevent hernias from getting worse? One, myofascial release. I should have put that on the top of the list. That really helps with, depending on the size of the hernia, but with hernias, because myofascial release removes the adhesions, the things that get stuck, so that basically things can glide better. And if things can glide better, then you turn it into an asymptomatic hernia. For example, I had a client, she's come to me, we've had 4 treatments. She was going to have the operation. She no longer needs the operation. She was going to have it because it was very painful and uncomfortable. And we were able to basically make her asymptomatic. And once you do that, they won't touch you unless it's an issue. Postural alignment. If you look at this lovely lady on the right-hand side, visualize the lines, okay? Don't just look at her standing like that. Visualize the lines. So at the moment, her rib cage is behind her pelvis and her pelvis is above, which is causing a stretch of the abdominal wall. It's going to cause massive constriction on the lower back, and she's going to have issues, fascial issues with the legs. Now, if she were to be obese, for example, or if she were to have a hernia that is asymptomatic or, you know, sort of minorly painful, that can be literally fixed by having the correct posture, because the alignments of the muscles are in exactly where they need to be. The ribs are above the hips. In theory, she's a little bit too anteriorly tilted, so her pelvis is tilting forwards a little bit too much. But that's okay. That's just me being pedantic. Now, if you look at this chap here, he is probably not engaging his abdominal wall. So everything's hanging out. So that means that there's going to be a massive amount of pressure on the abdominal walls with his organs if he were to have a hernia. So if you were to sit up a little bit better, the diaphragm would be moving better, he would be breathing, and he would be breathing into the upper cavities, not just the abdominal wall. Bodybuilders, as I said before, they are great at being tough and hard on the outside, especially the shoulders, the back, but they're not necessarily great at engaging the core. Many bodybuilders have hernias and diastasis. Yoga, you can see the posture. Some people can really, you know, they're so into, if you look at this lovely lady at the back, she's so into like really, really showing that she can do the posture, that they're overstretching that connective tissue. So what do I do when I am working fascial work? I do a combination of things. It really depends on each client and the hernia that they have. But I predominantly start off with working with the thoracolumbar fascia, which is basically, for those that don't know their anatomy, it's a massive fascial sheath in the back of your back. So it's like a big shape diamond in your lower back predominantly. So I would work that. I would start off by doing, you know, sort of doing the whole back, doing a nice treatment as well. So, you know, sort of double fist going down the erectors, and then I would really focus on my forearm. I am hypermobile in my fingers, so I tend to use my forearms and my elbows for most things. I would use very little ointment, or I use wax, so very, very little wax. And I would really work on connecting. I'm not in a hurry. It's not an efferage as it normally would be. It's a myofascial efferage. So it would be locking in from the ribs, bringing it all the way down to the hips, and then possibly going up and down, and really warming and heating that whole side of the body. I would also then strip with knuckles down from the spine all the way down. I would work the QL area. I would also work the glutes and the iliac crest. So, you know, sort of at the back, all of that area I would think of releasing. I would look at trigger points, if there's any trigger points in that area. I would stretch out the arm. I haven't written this down, sorry, but I would stretch arm. I would grab the arm and stretch it to do a side stretch, gliding my arm or my hand along the side body. Skin rolling, I'm a little bit hesitant with skin rolling. I don't know who's put their speaker on, but it's echoing, guys. So skin rolling, I'm hesitant with skin rolling because it can be excruciatingly painful for someone. But if their connective tissue is really, really, really stuck, then I would do skin rolling, and I would focus on releasing the spine and going down the side of the body. So predominantly in the lumbar spine. So focus on the whole of the lumbar coming down, and potentially a little bit in the iliac crest. Right, myofascial release of the abdominal muscles. I would not work directly into the area that has the hernia. So what I mean by that is sometimes direct contact is you've been taught that you kind of press with your fingers to release a trigger point. You press with your fingers to release the psoas or the iliacus. That's not a good thing to do when you have a hernia, because it's too much impact. That connective tissue is already soft, or it's already fragile. So what I would do is I would do potentially a cross hand stretch and just sit and wait with it very, very slowly. So I would do one half of the body, one half of the abdominal muscles facing the linea alba. And then I'd go to the other side and do the other side, gently pressing down towards the organs and really feeling that fascia. I might do, if it's an inguinal hernia, I would not do it on the hip flexor area, because basically you'll be pulling it up. You'll be pulling it open. Okay, so you've got to be mindful as to the direction of your pull or the direction of the fascial release when it comes to the actual hernia. The other thing that I would do is a fulcrum. So a fulcrum is kind of a twist. So if you think of the shape of the rectus abdominis, obviously, if you have somebody who's obese, it's very, very difficult. When you have somebody who's obese, you need to literally grab their entire tummy and you twist it towards the area that it wants to be twisted. So, you know, you'll know because it's kind of, it will feel more comfortable one way or the other. And then I would, if they're not obese and I can actually feel the sides of the rectus abdominis, I would put my thumbs and my fingers and I would literally clasp it as if I'm kind of doing a massive bunch. I don't know if that makes sense. When we finish the presentation, I can explain it a little bit better. If it's an inguinal hernia, I would focus on the legs, the IT band, the adductors, the quads, the hamstrings. And basically you need to think, okay, it's an inguinal hernia or it's a femoral hernia. You're trying to release the pull from the legs up. So you're making sure that the fascia can go up, and then you're trying to release the diaphragm down. Okay, notice and check how they're breathing. Are they breathing into their tummy or are they doing shallow breathing? And if they're doing that, then do a tummy sandwich and focus your intention on the diaphragm, because you need to release that whole area so that there's more movement. Now, what do I recommend for you guys is, one, learn your anatomy and your fascial lines. That's really, really important. You need to learn to teach myofascial release stretches, and you need to learn to teach how to align yourself and engage your core. So let me, how do I do this? Stop share. Okay. Hello, ladies. So I know I went through that quite quickly. I realize, I'm sorry. When it comes to teaching the stretches and teaching the alignment, when it comes to that, for example, if you join me on this very simple stretch, we're going to stay seated. I want you to lift your arm and stretch your arm. So when we say to our clients, right, you know, I need you to do a side stretch. What do you normally do? You kind of lift and you say to them to go to the side. Yeah, I'm assuming that that's kind of what you think of doing. So I want you to now focus and do this with me so you can feel the difference. I want you to lower your shoulders. So imagine that your shoulder blade, your scapula, has a pocket in their jeans. Okay, so you're going to inhale. And as you exhale, start lengthening up. But as you lengthen up, feel that you're lengthening from your armpit. And then release your lower back, because your lower back's going to be gripping. Really ground your hips into the chair. And then rather than gliding and coming up and over, think of sending the elbow up and over without bringing the tension into the shoulder. And then think of sending the ribs that way. And breathe. And keep going as far as you can without gripping on the opposite side of your pelvis and rib. Yes, okay. So Tanya, I think you gripped on that one, didn't you? So I want you to focus on the rib cage of the arm that you have lifted. Send the ribs the outside, send them that way. Yeah. Can you feel that stretch? Now release the shoulder, because your shoulder will be gripping. And then let it go. Okay. Can you feel, you're more than welcome to unmute yourselves now. Can you feel the difference between a fascial stretch and a normal side bend.
Yes, it's completely different. Completely
Yeah.
different. Yes.
So you need to educate your clients. You need to teach them to feel the right thing. And one of the things that you do is practice it. See how you do it first. Yeah. So see, okay, if I focus my intention, do the other side for a second. If I focus my intention on my hand, on sending my hand, how does that feel? And then if I focus my intention on sending my elbow up to the ceiling, how does that feel? And then if I focus my intention on opening my armpit and sending my elbows sideways, how does that feel? And then if I breathe and I send my ribs a little bit further that way, but instead of sinking, I'm sending my spine up and over, how does that feel?
Mm.
And release. You can see the difference, yeah? So fascia is really important to work with, and it's actually quite simple once you know how. But you've got to think that the connective tissue is everywhere. And when it comes to dealing with hernias, you've got to think of the human being as 3D, not just the hernia. Yeah? Think of the organs. So when you're doing a tummy sandwich, do you know what that is? Yeah. So for those that don't know what that is you have the person lying down, you put your hand in their lumbar spine and you put your hand on their tummy. And then just try it, as one of my amazing tutors that I know, Stephen Goldston, I don't know if you've been with him. He has this motto is that, you fake it until you make it. And I loved that theory because it's kind of like if you learn to feel inside their organs, you can develop your listening touch to literally feel the connective tissue inside the liver or inside the kidneys, or how things are feeling in the intestines, and you can literally feel it. It's amazing. It's mind-blowing. But it's just a question of holding and then possibly, move your hands like this for a bit, see how that feels. And always go towards where it wants to go. Don't go against the flow. Always go with the flow. So if you feel that, okay, the diaphragm's a bit stuck on one side of the rib and not the other, see, okay, well, where does it want to go? Where do I need to push gently? And if you're finding that you're pushing and you're finding that you're tight, you're putting too much pressure. If you're able to relax and you're breathing, the more you breathe, the more you're going to connect with that fascia. And always tell your client that fascia will not move unless they breathe. So if they're taking deep breaths through the treatment, you will see that the moment that you're stuck and they suddenly take a breath, it suddenly goes and it starts moving. Mm. And don't panic. Don't think, okay, I've been sitting at this spot for what feels like a century. It might be a minute, and a minute is actually quite a long time, okay? But if you just relax a little, suddenly it will give. And if it doesn't give, then move to a different position or move your hands to a different position. Does that make sense?
Yes, yeah. I've done the MFR 9-day MFR course with Jing, so I do a lot of fascia work. Yeah.
Brilliant. Now, have you got any questions for me? And by all means, if it's not relevant to hernia, throw what you want, and I'm here to help. I'm hoping that the presentation covered quite a lot. Yes, I don't know how to pronounce your name. Siti Salahma?
Siti, you can call me. Hi.
Hi.
Hello. When you do the stretch, I get a what you call it? There's a word for it, but I can't remember now. Stitch, that's it. A stitch on this side, and when I do that, it's a stitch on that side.
Okay. when you're doing that side stretch. Okay, so what I want you to do is focus your intention. Okay, so do it with me one more time. So you're going to lift that arm, but I want you to think of your spine. Okay, so send the spine up, send your atoms up, and then start sending your body sideways. And breathe. How does that feel? Does that feel a bit better?
Better, yeah.
Yeah. And the reason why the stitch was happening was because you were so focused, and this is where intention is magic, guys. You were so focused on the elbow, on sending the elbow over, that you were actually contracting your obliques on the other side. Okay, so what I need you to do is not contract the obliques. What I need you to do is focus on the actual side that you're trying to stretch. But how does that stretch? It doesn't only stretch upwards, I mean, sideways. It stretches upwards because your spine has to go with you. Does that make sense?
That's really interesting, because it's like the I can remember years ago from yoga classes, you know, standing there doing a ear to shoulder, and then a Pilates teacher said a couple of years ago, it's not ear to shoulder, it's ear to ceiling. Yes. And the difference is just, and I do that so often with clients, and the difference, you know, you can see their faces go, oh yeah.
Yes, absolutely. And the thing is,
right down into the deltoid. Yeah,
you're contracting rather than lengthening.
Yes.
Can I ask a question, please?
Yeah, of course you can.
When you said you're treating clients with a hernia, you're stopping them from having to have a surgery, what is actually happening to the hole or where it's protruding? Is it actually the fibres of the connective tissue are managing to knit together, or?
That's a really, really good question. Basically, if you envision your hernia, it's, you know, you might have a hernia that is like that isn't like that is just like that, okay, or a little bit. And you have adhesions in that area.
Right.
Or you may have adhesions round the back. So this is not the best top to show you, sadly, but if you envision, let's say I like that picture of the girl that was standing with the hips forward and the ribs back. Yeah. So what's going to happen is I'm going to have adhesions here, lots of them. Okay. And this is going to be opening up. Yeah. So either here or in any of the sides, it's going to be opening up. So what I'm doing is I'm just lengthening, letting go of that connective tissue, doing that, and then basically it has more movement. So because it has movement, it doesn't cause pain. And obviously, if we're talking about a hernia like the one that we saw of the image with, you know, practically the entire organs popping out, that's operation. That's, you know, you're not a magician. There's nothing you can do with that. You can help for the operation. So it's not a question that you can't do myofascial release. You can really help them so that the fascia and the connective tissue and all of it is moving, gliding, oxygenated. You know, you have the lymphatic system is no longer toxic because you've moved the area. You know, the capillaries are moving, all of that, so that when they get operated, one, it can heal, and two, potentially they won't get a second hernia. But when it comes to small hernias or umbilical hernias, you know, things that are not massively protruding out, then you can definitely, like I've done it many a times, that you can definitely make it better.
A case that they have to have like a regular maintenance treatment with you so that it doesn't come back, or how does it work?
Well, no, after, usually, because it's so honed in, it's usually after about 4 treatments, because I work the body. So I do a full body massage. And then the second treatment, I might start doing fascial work. And then I basically develop on the different areas. I might not be, you know, depending on how tough the connective tissue is, or how many adhesions, because obviously we're talking about trigger point therapy as well. So I do it in conjunction with trigger point therapy. If I'm going to be doing that, usually for maybe 6, but it's usually about 4 treatments that you can nail it. And then what tends to happen is that they really like it, and then they want to come every other month, or, you know. So I've never done a hard sell. I've always said, you know, this is what I do. If it starts bothering you again, come back and see me.
Mm-hmm.
And that's it. I mean, I don't like hard sells. I think that doesn't work for my ethos of my clinic. I always say, you know, see how it goes. Was it beneficial? I always double check. I'm always in contact with my clients via text. How did you feel? What side effects did you have? Especially because sometimes they might have a massive load or healing crisis, as I call it, from the myofascial release. Okay, because that's one of the things you need to be very mindful.
I've had that. Yeah. And it's quite scary. I mean, I had this wonderful treatment. This was before I did the Jing training, and I popped into Tesco's afterwards, and just had to stand there holding on to something with just waves of nausea. It was really, really peculiar.
Well, you have to remember, which is something that I've kind of become fascinated about. The lymphatic system sits in the fascia. Yeah. So if you're going to be working the fascia, you're moving toxins. And depending on how the person clears their toxicity, you're going to be potentially throwing a massive grenade into their body to have a clear out.
Yes.
Yeah. Mm-hmm. You know, I always check and you know, sort of depends on how it goes. Sometimes they say, you know, I had a huge bowel movement, and I was like, well, that's good.
Yes, better out than in.
So anything else? Any other questions that you've got for me?
Sorry, it's me again. I've got a hiatus hernia. And the doctor says it's because I've had 5 pregnancies, because I have 5 children. And so because of the expansion and my last pregnancy, which was 22 years ago, I could feel her coming up and up and up. So that's the reason why I have a hiatus hernia.
You have
and it's very troublesome.
Okay. I think if it's very troublesome, go to your doctor and get it checked out. Okay?
I've had all kind of colposcopies done, twice, and I'm now on omeprazole. But I've also realized that the stretching that you do, I've looked it up. That's very good because it lifts it up all the time.
Yeah. When it comes to hiatus hernias, even though we didn't really cover it fully in the presentation, it's all to do with posture. Okay. If you are sinking into your organs, everything's going to be pushing up. Yeah. So you need to strengthen your diaphragm by doing exercise, breathing exercises. You know, I noticed from here, you're not breathing into your rib cage. Okay, that's one of the things that I always look at people. You know, it's like, okay, how are they breathing? Are they actually moving here? Because you need to, if you think of the breath, it needs to go abdominals, thoracic, throat, head. It kind of goes all the way up and all the way down. Because if you think you have the diaphragm and you have your the other way around, you have the diaphragm and you have your pelvic floor. Okay, so they move. If you remember the image of the tummy in yellow, they are contained together. So you move this is going to move. You let go, and that's going to let go. Yeah? Boom, boom. So it's really important to focus the breath and think of a 3D breath so that your rib cage expands out, because you're 3D, and then let it go. Yeah? That's number one with hiatus hernias. Number two is the body alignment. If you remember, and I always say, think of atoms, they're going up. Think of your atoms always going up, or you're holding a crown, or whatever works for you, whatever image works for you. Think that you are upright. Because the more you sink, the more you're kind of folding all those organs in. Yeah? And yeah, I mean, pregnancy, if you consider, you know, you have the womb expands, the baby expands, and all the organs get shunted upwards. And you're probably quite a petite person. So if you think you're shunting all the organs upwards, and the thing that's stopping it is the diaphragm, it's understand, you know, the whole is, you've got the esophagus and everything's contained. But if you think of a balloon and you push it, it's going to do that, especially with relaxin, especially with the hormone that you produce. So it's going to do that, and potentially it might not go back. You know, it's the same as diastasis. You know, it can expand. In theory, it should go back, but it might not go back. So if sorry,
I'm well aware of that. And I can't wear proper bras anymore with wire.
Well, that's not a bad thing, because that helps your lymphatic system. You don't want bras.
Does depend slightly on your boob size. But I mean, that's why singing is so good, isn't it? I mean, I sing in a choir. Well, not at the moment, but that is, and it's always when you remember, because it's this thing about thinking so many things going on in your brain. You know, you've got conductor, music, piano, singers around you, and the thing that goes first is your breathing, because there's too much to concentrate. But if you can get it together, it's that support from right down at the perineum, which actually gives you the top notes, and having a straight line from going up through the vocal cords.
Absolutely.
Yes.
And that is the thing that you are working. One of the things I like to think of myself as an obsessive anatomist, because I'm constantly researching. It's my passion. Now, if you think of the psoas muscle and how the psoas muscle is attached to your diaphragm, okay, and the psoas muscle sits in the bowl of the pelvic bowl, okay, it sits inside the iliacus. So if every time that you take a breath, the psoas muscle is doing this. Yeah. So again, let's do a very simple exercise. Put your hands on your ribs. You can do this sitting down, but I'm just standing up so you can see the image. Put your hands on the side of your ribs. And then I want you, as you keep your hands there, I'm just going to talk it through. Imagine your rectus abdominis is a glass panel that goes in at an angle. Okay? So you're going to inhale, thinking of breathing into your rib cage. And then you're going to exhale and you're going to pull in that glass panel. Imagine you're exhaling by blowing out a candle. And then inhale again. And exhale. Can you feel how everything pulls in? Yeah?
Yeah.
So Siti, that is a really good rehab exercise for you.
Thank you.
Because you need to basically, the peritoneum works all together. So you need to make sure that it's doing this. so that your diaphragm connects down and lifts up. Then you're going to lift your pelvic floor. By lifting and strengthening your pelvic floor, the diaphragm and the pelvic floor are going to function together. Yeah? So hopefully the reflux that you're feeling should go.
Thank you.
Let me know. I'll be intrigued.
Oh, thank you. So the one of the other hiatus, the other hernias, epigastric, was it?
Yeah.
That's not the same as hiatal hernia.
No, epigastric is basically, if you think of the linea alba, which is the line in the center, you have the umbilical hernia, and epigastric is just above.
Right.
Okay.
Yeah.
Okay.
Can I just ask about the mesh?
Yeah.
So, so if someone's had a mesh, would you avoid that area with myofascial release?
I would if it was early post-operative.
So how long would you leave it before you were in that area?
I always work on the motto of it takes 14 weeks for a C-section to heal.
Right.
14 weeks.
Okay.
Or thereabouts.
So then everything will have meshed over it and all.
Be gentle, you know, it's not a question of poking it or really working hard on it. I would do more handholds.
Right.
And work internally. Because it's kind of, you're in a catch-22. You do want adhesions there because you do want it to glue and not migrate. But you don't want so many adhesions that basically everything's stuck together and that you're constipated or whatever.
Okay.
Does that make sense?
Yeah, yeah, thanks.
Oh, there's a weird buzzing.
Yeah, that's my laptop's got getting very hot.
So anybody else with? If you don't, that's fine.
Yeah.
City, I can't hear you.
I just want to
on mute.
I have now. I just wanted to mention that the advice you've given me now is very, very valuable because you don't get that from the surgeons and the doctors after they've discovered it. They just hand you a leaflet, say that you mustn't eat late or no spicy foods and check your diet and all that sort of thing. They don't go into the exercises and what you can do yourself to do it, you know, and I think it's quite valuable what you teach.
Yeah.
Thank you. So thank you very much.
Thank you very much. To be honest, I think it's because I'm slightly obsessed by fascia. And
yeah, I am too.
Join the club.
You know, I think when you work with fascia and you know your anatomy, you approach problems very differently. And that can be from hernias to pelvic girdle pain to anything really. You need to visualize your problem as 3D. If you visualize your problem as 3D, then you can fix the problem. Surgeons, they're lovely, but their passion is surgery. And their passion is, you know, any surgeon that you go to with a problem, they will want to cut you open. That's what they want to do because that's their passion. You know, and that's fine. But
there's a time and place.
But for them, that's really valuable. Sorry, City, what did you say?
What a passion to have.
Yeah. But you know, you've got to visualize that if it's not fixed, as in, if it's, how can I put it? If you can move it, you can fix it. Literally, you've got to think everything is connective tissue. You know, muscle, tendons, cartilage, everything is connective tissue. So if you can manipulate it and then educate, you can fix it. I have no doubt of that. The only time that you might say, well, but it didn't work with that client, is, well, did you educate and did that person listen?
That's, yes, that, I mean, that's so, because you can talk to some people till you're blue in the face and it just it doesn't go in. I mean, I've got, well, my other half actually can't get that connection with pelvic tilts, for instance, to try and engage the muscles at the, you know, the bottom end. And when I say, you know, it's a pelvic tilt, it doesn't compute. There's a,
so
whether it's
talk anatomy. Say, okay, and laugh about it. I'm very frank with my clients. I have no embarrassment. I talk very, very frankly. And if I had a man that didn't know how to pelvic tilt, I said, okay, how would you shunt your penis forward?
Yes. Yeah.
You know, and suddenly it's like, oh, that's what you want me to do.
That's what you mean, yes.
Yes. Whereas if you say pelvic tilt, they're like, well, I don't know, what does that mean? So there are moments with clients you need to bring it down to the basics, like literally.
Yes.
You know, I had a client on Friday, and he was new. He was lovely, but he's an athlete, and he doesn't have time. You know, you talk to him and you can see that he's not listening. And he came as an emergency. He was in absolute agony. He could barely walk up the stairs. He did something to his groin area. And I did some fascial release all over. And then I turned around to him and I said, okay, I'm going to go really deep in your groin area. And I don't want to be touching things that I shouldn't be touching. So I need you to cup yourself. And he went, oh. And I'm like, you know, let's just be frank. And it's that you just need to build a rapport and not be embarrassed.
Yes.
You know, and that comes from inguinal hernias, femoral hernias that, you know, are in very delicate areas, and you're going to have to work the adductors, you're going to have to work the pectineus, you're going to have to work all that area. You know, make sure that your draping is good, and don't be embarrassed. You know,
well, been around long enough not to be, I mean,
well, I'm really, really glad that you guys have enjoyed today.
It's been really interesting, and I'm thinking actually, you know, the fascia work, so important for any kind of pre-op. You know, I'm thinking of, I mean, I've been working with a couple of clients with sort of rehabbing frozen shoulders very successfully, but you know, thinking of one that I had a few years ago who'd had a terrible adhesions after a hip replacement, and thinking now, blimey, if I'd had her as a client before she had the hip replacement, she probably wouldn't be in such a pickle now.
Absolutely.
Yes.
Absolutely.
Yeah.
100%.
Yeah.
You know, whether it's post-operative or whether it's giving birth, you know, make sure that their fascia is moving, because you're not only moving the fascia, you are moving the lymphatic system.
Yeah.
And the lymphatic system is as important as the fascia, to a point sometimes even more.
Yes, I mean, from the point of view of healing generally, health.
Yeah, because you think that you're about to go into an operation and your lymph nodes are blocked because you have a toxic type life. And then you add to that all the toxicity that you're going to receive in the operation. Your healing is going to take a long time.
Yes.
And you're going to have a lot more adhesions.
Yes, yeah, and if you've been on painkillers for a long time pre-op, which, you know, happens to so many people. Yeah. Yes.
So if you don't have any questions, I'm going to leave you, but I would love to ask you a massive favor. If you could, I don't know if you're on my Facebook page, but I'm thinking of doing more of these. I'm thinking of doing one for pelvic girdle pain. I'm thinking of doing, I don't know, I love giving information. I love educating people. And I think today's gone okay.
Yeah, it's been really good.
So if you really liked it, please, can you leave a review? And if you don't know how to do that on Facebook, just send me an email, send me a message with a review so I can actually put it on my website, because I am going to be doing more of these. So it would just give me a little bit more, actually, she's done it before and it was good.
And we'll be back.
That would be awesome if you did.
Oh, that's been great. Thank you so much.
Thank you
very much.
Thank you very much for
Take care,
your
guys.
knowledge.
Have a good one.
And lovely to meet you all too.
Yes. I was hoping to have seen Dawn, but she's not
Thank
here.
you very much.
No, and by the way, if you ever need, if you're stuck with a client or you're about to receive a client and you're like, oh my God, I don't know what to do, or you have a condition, try me out. I might be able to help.
Mhm.
Okay,
Brilliant.
so my door's always open.
Brilliant.
Thank
Yeah. Thank you so much.
No worries, guys. Bye.
Take care, everybody.
Take care. Bye-bye.